Okay, so we'll get started. Thanks everyone for joining for today's webinar with Dr. Chris Bollen and Professor Len Gray, subject matter of the 75 plus assessment. And before Len introduces himself and Chris, I'd like to do acknowledgement of country. I assume that you're all joining from different parts of the country, potentially different parts of the world if you're joining us from outside Australia, and welcome. So on behalf of the University of Queensland, I'd like to do an acknowledgement of country, not just for the country that I'm situated on here at Hurston in Brisbane, but for all of those other First Nation countries you might be joining from in Australia. And so the University of Queensland would like to acknowledge the traditional owners and their custodianship of the lands on which we meet. And I'd like, on behalf of the university, to pay our respects to their ancestors and their descendants and their continued cultural and spiritual connections to country. I'd like to recognise the valuable contributions to Australian and global society. Okay, well, thanks everyone again for joining. So I'll now hand over to Len, who will do some introductions.
Thanks, Murray, and thanks particularly to Chris for coming along and sharing some what I think will be very interesting thoughts about 75 plus assessments. And I'm sure he's going to say a little bit more about the world than just 75 plus assessments, knowing him. Chris and I have had a couple of chats in the last year, I think, just happened to kind of run into each other and got talking about some of the issues about aged care and how it relates to primary care, and specifically about 75 plus assessments. And being an interRAI kind of person, I kind of have for quite some time seen some opportunities to inject some interRAI capability into this process. And of course, being a geriatrician, I'm interested in the whole process and how it can support older people in the community. And I've found that Chris is a strong advocate for this process, along with many other aspects of general practice. He's certainly very knowledgeable about what the needs of older people are, and he's obviously gets his hands dirty doing this kind of work fairly often. And I won't go on too much about Chris, but he's a very accomplished GP and has been very engaged in policy related work as well. So he's a person we should carefully listen to. As he talks, you're welcome to place questions and comments in the chat. Murray will be watching that, and Michelle, and we'll use your comments potentially to inform the discussions towards the end of this session. So without any further ado, I'd like to hand over to Chris, and he's going to talk briefly, more than briefly, about matters related to 75 plus health assessments. I'll make some comments about how interRAI might interact to that towards the end, but we're mostly here to hear from Chris. So thank you, Chris. Thanks for coming.
Thank you very much, Len and team. And just confirming that my slide is up on the screen.
It is indeed. Perfect.
Okay, fantastic. All right, well, that's right. Well, I work clinically a couple of days a week still and do a lot of work educating doctors, nurses, allied health professionals around Australia and the concepts of care of older people, but also leadership in primary care. So I have a couple of different hats I wear. So our little Bollen Health Consulting Group, which my wife is a registered nurse and I work with, we get to work with some fantastic primary care practices around the country. I really want to get you to think a bit about what we could be doing in primary care to improve the health assessment for older people. And Len sort of said, right, let's talk about some of the challenges and opportunities. So I think one of the big challenges for all of us on the call today are really thinking a bit about, well, why do we need to do what we do as we're clinicians? Frailty is going to impact a lot of us as we get older. And Ruth Hubbard from UQ as a geriatrician certainly, I love this quote, more than 20% of people become frail as they age, and it is the most significant challenge to aging well in Australia. So I challenge general practitioners and their nurses and their practice managers and allied health. What does that actually mean for their practice in their everyday work? Because certainly the demographics of aging is impacting Australia in a big way. It's fantastic, but it means that GPs and nurses and allied health professionals are now seeing so many more people. So one of the things that I wanted to look at was this frailty issue, and is this something, if it's 20%, then what's happening? Are we actually recognising it? Because over the last decade, since I've been doing a lot of work in the care of older people space, frailty's been something I've been talking and thinking about, but not many others in Australia in primary care have. Clearly in other parts of the world, frailties being recognised in primary care. So this was something that made me think about, well, what are the barriers to doing what really matters? And, you know, frailty is so important, recognising it and doing something about it, and understanding the evidence that we can change trajectory if picked up early enough. So I wanted to know, what were the barriers to actually having this recognised? And so part of what I have been doing, and my wife Jane have been doing, we're working with a number of primary health networks around the country to work with practices, running workshops, running programs to help support people to understand what frailty is and what they could be doing differently in their practices. So I presented up on the Gold Coast in November last year, where I caught up with Len, and I will present some of those findings, but we'll also present some other areas that we've been trying to get people to think differently about the health assessment, which essentially in Australian general practice is a great proactive opportunity. But look, you know, in practices, and this is a survey that working with practices, what were their barriers? And certainly, you know, time is a big barrier for GPs and nurses. With, you know, 10 to 15-minute consults, they didn't have a lot of knowledge on what frailty was, didn't know what to do about it. The cost issue was about, you know, where do I refer people, where, you know, the current Medicare system is that they already use most of their Medicare funded services on podiatry and they only get 5 a year. A lot of the aged care providers, once a person on a package, you can't actually refer them for a frailty busting package, also known as a reablement package. So there's these gaps here. So they're really interesting. But, you know, this big one, okay, if it's not in my health assessment template, I'm not going to do it. So we also need to understand what were the big issues for working with older people in primary care. And so this essentially, the word cloud comes from the probably many hundreds of people that have been in our workshops over the last 7, 8 years. And so really time and complexity is what people are facing with managing lots of older people in their practices. And this is actually getting them, they're struggling. They're really, really struggling because it's the MBS system, which essentially remunerates them for time, is not helping them deal with complexity. So when we think about how we need to understand and or how we solve issues, we need to look at all the barriers and think differently about how we can deliver this care. So currently, funding seems to get in the way, as well as the issues of time and complexity. So those of you that are on the call that understand Australian primary care will know that the MBS is, and which is Medicare, has a health assessment item number. So this is drawn from the book of numbers, which all GPs, practice managers need to know to be able to effectively survive and be sustainable. So the government has got this descriptor. And so you see that this is what it said. And this has essentially been very much unchanged over the last 15 years. So really a health assessment for an older person must include a blood pressure, pulse rate rhythm, medication assessment, continence, immunisation. But interestingly, it only states those 3 immunisations. We need to assess a person's physical function, their psychological function, some social function, and it can only be claimed once every 12 months for a person aged over 75 in a practice. So that's what we are. That's what sets the tone for us in general practice. This is what the government says we should be doing, and that's what we'll get paid for. Now, the RACGP, which is our overarching professional body, this is it from its curriculum statement in 2022, when they've, for the first time, really expanded what a thorough health assessment of an older person should actually cover. And these are really important areas because you can see by comparing what the government says is the must-dos, we now start seeing we need to be thinking about the big issues for older people: chronic pain, wound care, nutrition, frailty is now mentioned, issues about neglect and abuse. Are there osteoporosis screening? So all these things now start saying, there's becoming a bit of a gap between what we should be doing and what the government MBS descriptor says we must do. Now, why that's important is because our software vendors are the ones that basically are what we use every day to do our health assessments. I'm going to talk a bit about what they offer. But all of us on the call will now understand that getting evidence into practice is such an important part of delivering better care. And so study after study seems to keep saying there is a gap between new evidence and getting it into practice. And so in primary care, we're often the last ones to actually get our practice change. And so we really need to think about how we can improve the uptake of evidence. There's plenty of guidelines in primary care that we get to use and get to know, and they're updated regularly. This 9th edition of the Red Book is now the 10th edition, and for the first time, the college has put frailty assessment in there as a excellent opportunity for preventative activities that have lots of evidence to actually say we need to be doing it. The Silver Book looks at the care of older people. We've got the kidney health, chronic kidney disease management, primary care that was updated in March of this year. And we've got the guidelines on vaccination from the Australian Immunisation Handbook, which talks about the updates in pneumococcal vaccination, shingles vaccination. So all these things are fantastic evidence-based sources. But the real problem, going back to our slide earlier, about getting this evidence for all of these great things into practice, it takes a long time. And we really need to go, right, well, how's health professional knowledge on many of these things? So I took a survey of our health professionals in our workshops and say, what do they know about frailty and many of the other things that we're talking about that need to be done in 2024? They don't know much about frailty. They think it's normal aging. They don't think much can be done. They don't know what the screening tools are. They don't have access to any objective assessments. And I've only come across 2 out of the probably 100 practices we've worked with that had a dynamometer. The dilemma about nurse training in general practice, there's no program of training that's actually fit for the role. The college hasn't been talking about frailty up until this year when the Red Book came out. They finally started saying, right, this is an area that needs to be discussed. And a lot of GPs, they feel as they're getting old, they are not recognising their age-related changes in their patients. So I also then had a look at the gaps in primary healthcare professional knowledge. So really interesting. So 234 people completed the survey. 75% had no formal training in older people's health issues. But half of this group did health assessments for older people, and they absolutely rely on the software template to do what is required. So that's a really important area to understand as we go into this next area, that the reliance on the general practice software is huge. So that made me think about, well, let's look at an audit, because audit is a fast way of getting to understand what we do on a regular basis and matching it with the evidence for what we should be doing. So I worked with the Gold Coast Primary Health Network to implement an audit program for practices in the last 2 years across the Gold Coast, where they could review their practice data, some various clinical indicators for care of older people living in the community, help them understand what their gaps were in care, and looked at what potential system improvements might be needed to actually help improve the care. And part of it was also based upon, can we implement a screening tool for frailty? So the audit process was really about looking at 15 people that had had a health assessment the last 15 months. They had to be community dwelling, and I got them to reflect on what their care gaps were. So part 1 of the audit was, this is a generic practice extract of their data. So we had a look at what was happening in their practice when it came to how big was the size of their population. And so this practice had 24% of its active patients over 65. The national population over 65 is currently 16%. So we found very quickly that older people are overrepresented as active patients in all the general practices, and some practices had 20% or more of their community practice over 75. We got them to look at their influenza vaccination rates, pneumococcal vaccination rates, shingles, medication reviews, because we feel that's a clinical indicator of, well, are you getting the medication reviews? Then this is the pharmacy one where it's an item 900, where the GP and nurse refer a patient for medication reviews. Looking at health assessments, this practice had definitely a very good uptake. The national average for health assessments for older people is only 20%. And that's Commonwealth data, but this practice had 80% of its older people. They had a way to actually get them in and get it done. And so the recording of height and weight was very good, but they didn't understand what frailty was until we started talking with them. So frailty is now a coded diagnosis in the software. And issues of chronic kidney disease and dementia, we were able to look at their coding rates. I put together a 3-page checklist where they went through and looked at, was there any evidence of nutrition screening tools, and a whole raft of different things that the Red Book and various guidelines on care of older people that the college sanctions to help them think, were they doing what the evidence suggests they should be? So then we really then need to introduce our viewers to the software. Medical Director and Best Practice roughly has 90% of the market in Australia. And just thought I'd put you some screenshots up there, because this is their front pages. And here they are, Best Practice saying trailblazers in medical software, practices depending on it so they can focus on what matters most to their patients. And so the same thing with Medical Director talking about ideal healthcare. And you'll see the Telstra note up there. Telstra owns Medical Director. So that's really what our GPs are auditing. The offerings of both these software vendors have templates for health assessment, and essentially the GPs were assessing what they're offered versus what they needed to be doing. So I'm just, as a best practice user, I've just got some screenshots here just to show you. So in the health assessment for best practice, this is a social history template, and it's nice. It has the advanced care directive. It's got a drop down there. You can actually put that in there. So that's really nice. And a bit about accommodation and about whether they've got a carer. So then it moves to the basic functions. So really this is where it starts falling down. Mobility, it's got a little drop down there, which is nice, but adequate nutrition, yes or no. And so this is really, when we looked at the audit, the doctors and nurses were saying, well, how do we assess nutrition? There's not actually any guidelines here. Adequate exercise, yes or no. Adequate sleep, yes or no. Continence, yes or no. The vast majority of doctors and nurses go, right, this isn't adequate for our needs anymore, as we've helped them understand what the evidence is. But interestingly, the cognitive impairment assessment, this little thing called the mental state examination, if you actually click on this, what comes up is this nice little mini mental state examination. It scores the person for you, and you can actually compare with previous examinations. So that's really neat. But going back to the previous slide, there's nothing supplied with exercise and nutrition and other elements here. So these are big gaps the doctors found. So this is why many things don't get done proactively in general practice. The assessment of function is very rudimentary, so it's really just a tick box, and this is leading to a lot of dissatisfaction amongst nurses and doctors, because it is just simply ticks box. It doesn't come up with some great recommendations. It doesn't solve the issue of working with people when you are time poor and complex. Ticking boxes doesn't then lead to, don't forget to make this recommendation. So when we look at where smart software is in 2024, this is actually creating low value care in practices and low value activity in a time poor context. So that's one of our big challenges. How do we actually add back value to our practices? So when we look at where the gaps were, so the doctors and nurses have reported in their audits that there's no screening tool for frailty, nothing for undernutrition, no discussion of osteoporosis risk, no discussion of risk of chronic kidney disease, no reminder to actually do a kidney health check, when we all know as clinicians who are on the call, 40% of this group have chronic kidney disease. and very few are being coded. So I see this as one of the major safety and quality issues in Australian primary care, where half of the group are currently taking 5 or more medications and most of them aren't being coded. So the software, which is actually designed to pick up the drug disease interaction of renal disease and any medication issues, it doesn't get to be used properly, because if no one codes, it doesn't remind us. It also shows that shingles vaccine status is a gap. It does not ask when the last one was, when the next one's due. Same with COVID. And interesting, so much changed over COVID. If you think about our healthcare system, we were able to get changes in MBS item numbers, changes in so many things done within around about a 4 to 12 week period of time. Yet we can't get our software to change to actually ask these basic questions. Another gap, it does not ask you or remind you as a assessment, as a proactive element, to do a laying and standing blood pressure. So we know this is a common issue, common cause of falls, and a common problem with medications. We aren't asked in general practice to do this as a matter of routine. There's no discussion about muscle health checks. We know the evidence is so strong now to look for sarcopenia for people over 75 because we can do something about it. So no one is actually using grip strength, 4-meter walking tests, or the timed 5 sit stands, or the timed up and goes, which we all know are currently used by other parts of the healthcare system. It doesn't ask us about the quality and type of exercise being done. We don't get to track the minutes of exercise an older person might be doing. And it doesn't request us to put in the name of the aged care package provider and their contact is, which is so vital. I, as a GP, I use those details every single working day to try and interact with a provider to actually let them know about a change. Some of the other challenges that our doctors and nurses, frailty screening is not in our health assessment template. They go, why is it not there? Why? And how do you change templates? Because that's what they need to be guided by. So I've been to our software vendors, Medical Director and Best Practice, and they've simply said, well, it's not their to actually to do it. They simply see this is, from my interactions, their clients, so the clients are the practices and the GPs that use them, compliant with legislation and compliant with Medicare. So the MBS health assessment template says the bare minimum, then their template will reflect that. The Commonwealth changes the MBS descriptor. So to actually, opportunities, this is something that Jane and I have sent to all our practices that work with us. We help them with auto for the software, how allows you to actually do what you do. But you've got to remember to use it. So we create auto texts, and we've then added a whole raft of things about links to nutrition screening, links to sarcopenia assessments, osteoporosis check, all in that what we call /frail, which is the auto. So, but you've got to remember to actually do that. You've got to make sure that everyone in the practice is aware. So there's a systems issue here. This is simply a band-aid to help reduce the gaps. Because really, when we look at frailty as a concept, we know the evidence is really strong. If we're going to actually try and reduce the risk of frailty on our older population, we've got to increase people's activity. We've got to vaccinate correctly. We've got to optimize medications. We've got to get people working, socializing and interacting, and we've got to recognize undernutrition and increase protein. So we look at this from Canada, the Avoid Frailty program, then our health assessment needs to actually having all these things as the bare minimum. And the templates that we use in general practice must actually show all of these elements. Because if we then don't act on these elements, we can't get the benefits for our patients for proactive health checks on an annual basis. Many of our doctors and nurses basically say they're struggling to keep up with the list of things that patients come in with that need dealing with. I call it the shopping list that they have to do in 15 minutes. So often they don't get an opportunity to have their proactive care. So I know that's been a pretty rushed approach to looking at some of the issues in health assessment in general practice. I hope that's given you a little bit of a discussion for what our challenges are and what potential opportunities are. The big ones are working with our software vendors However, they seem to be quite negative about doing anything about leadership of better care of older people. So we need to think about new ways, and maybe, you know, this webinar might trigger some ways to think differently about how we deliver better care to older people in our community. So thank you.
Thank you, Chris. That was fantastic. You've given us some really interesting insights into pragmatic problems that are stopping us, doing best practice. Actually, I think that's the key message there. Is many people know what to do. A lot of people follow by using software templates, which is a logical thing to do. It makes sure your documentation's right and everything. But if that's not configured correctly and it doesn't help you make decisions, then that's a massive problem. So very.
And Len, I didn't actually mention, but those templates that we've been using are basically the same as when it was first implemented in 1999. So for the viewers that are watching, it's 25 years now since those templates started. And so we're all of us that are going to see our GPs are using templates 25 years old. So I'm sorry to put that in, but that's the sad reflection of what our software vendors are doing to help improve care of older people in this country.
Okay, so I think we should talk about that a little bit more after I've had my moment in the sun, which will be fairly short. But I did want to kind of reflect on what you said, and in the context of what we do. Many of the people on this call are here because they've got some interest in interRAI. I'll give a brief overview of how interRAI might interpolate itself into the world that you're talking about, and then we can have a narrow or broader discussion about interRAI or anything else when I'm done. So just going to talk about interRAI briefly and how it might play a role in assessing older people in the primary care practice setting. Obviously, a lot of interRAI systems are used in aged care programs specifically around the world, but not so much use in primary care, either within this country nor anywhere else. And it's an area of great interest to interRAI as an organisation. So first of all, it's to remind us all of what an interRAI system is. It's basically a suite of clinical observations, and Chris was just illustrating in his demonstration of the software that's out there. There's a lot of focus on clinical observations within the software, but perhaps a little different than what the software was doing. interRAI basically builds a whole suite of applications based on those observations, scalar measures, screeners to identify problems like dementia, for example, or estimate risk of something happening in the future, like falls and so forth. Suggestions about what interventions would be appropriate, thing that Chris alluded to, that's very much lacking in the software. interRAI focuses a lot on, okay, if you've got this suite of problems with this set of risks, what are the interventions? And then, of course, an interRAI system also delivers quality measures, outcome-oriented quality measures, and in some settings, builds tools to understand cost and even provide a basis for payment. And out of this information, one can build a summary profile. And when one would do a 75 plus assessment, for example, you'd like to see a summary of what your observations are, how they're interpreted, and then that could be summarized for either the individual doctor or for other audiences, even in this case, maybe a version of it for the patient themselves. The second thing to say about interRAI is that it's not just system and the system that is targeted towards primary care practice is called a checkup assessment, but it shares a lot of content and applications with many other systems that interRAI has built, including, for example, the home care assessment, which is used in community care programs, aged care, but also lots of other programs. And then interRAI has other systems that share the same kind of concepts, the same data, and the same scalar measures across the various settings, including long-term care or nursing homes. And the way these systems are designed, there is a set of measures that are common to most of these tools, and a set of scales like ADL scales, depression scales, and so forth. And these are present in most of the systems, and then there are setting specific items. So there would be some elements that would be very specific for primary care, for nursing homes, for home care programs, for palliative care and the like, that aren't necessarily relevant to other kind of settings. But that's kind of how interRAI looks in general. There's a system that's relatively new within the interRAI world called the checkup system. It's specifically been designed to do something like the 75 plus assessment for primary care. It focuses mainly on the functional and psychosocial information. It doesn't, some of the medical things are not in the assessment, although there is an opportunity to record diagnoses, for example. But it really gets at the issues that are generally a lot of doctors don't think about too much, but are really quite important for older people and how they live and how they survive. So it contains about 83 observations. Sounds like a lot. That's actually relatively short as an assessment system, and across 8 domains. There's actually more domains than that, but that's the headings in the assessment. There are some supplements, and one way to use these assessments is to kind of use a core assessment for persons of relatively low complexity, but when one identifies people with more complex needs, maybe a more detailed assessment is appropriate, and there are ways in which you can trigger those supplementary assessments in a software solution. The other interesting thing about Checkup, it has both self-reported and assessor-based versions. And one thing to think about is, given the time poverty of nurses and GPs, to what extent some patients at least would be able to self-report in advance of having an assessment. That might actually help with the resource consumption aspects, but it also might improve engagement for some of the individuals that do assessments. And the self-reported versions correlate pretty well with the assessor-based versions, and they lend themselves to checking once they're completed. But that's another aspect of this that we could explore if we got stuck into thinking about this. So here are the 8 domains that are in the checkup assessment, very familiar to most of you: cognition, communication, mood, well-being, functional status, ADLs, IADLs, so forth, various things like continence, nutrition, lists of diagnoses and symptoms, and treatments that the person is receiving or should receive, and finances and stressors in the home context. And together, I said there's 83 items. So I looked at Chris's list from 1993 or whenever it was invented of what's in the regulatory requirements to do a 75 plus assessment, and most of the content, apart from the blood pressure, pulse rate, and rhythm, interRAI doesn't demand a full medication list in its assessment, but it does have questions about medication. So it partially meets that requirement, but the other elements are all there. And of course, an interRAI assessment interprets this information. It doesn't just collect it. It then translates it into scales. It translates it into suggestions about how one might react to the assessment. And so it provides a whole suite of other dimensions beyond just collecting information. And so outputs include risk assessments for issues such as falls or undernutrition, diagnostic screeners like for cognitive impairment, depression, and there's severity measures or outcome measures like ADL scale, pain scale. And Chris said quite a lot about frailty, but if you do and Ruth Hubbard, my friend, knows only too well, if you do an interRAI assessment, you can calculate a frailty index without any additional effort. And probably the preferred method of measuring frailty is to calculate a frailty index. The reason it's not done often is because you need 50 plus observations in order to calculate it. But of course, we have 83 in this assessment. And from all the research we've seen in interRAI, you can easily calculate an accurate frailty index from most interRAI assessments. And we've certainly done that work in the acute care assessments and in long-term care and home care. And it would equally apply to the checkup. So having done this assessment, one of the products would be a frailty index, which is a scale that is more sensitive to change than the traditional ways of the other alternative methods of measuring frailty. And of course, there are prompts for further management that are based on evidence and a lot of data that interRAI's looked at in terms of identifying who has bad outcomes and opportunities for improvement. So beyond the 75 plus assessment, there are lots of opportunities, I think, to make use of an interRAI world for primary care. Remembering, and I'm sure Chris can think of other examples, but GPs are the primary medical providers for residents of long-term residential care, where in many jurisdictions, the interRAI long-term care facility assessment, a larger version of the checkup really, is collected. And Chris, you'd be interested to know we're in discussions with government now about using interRAI for home care and potentially for long-term residential care in Australia. So if that were to happen, as it happens in New Zealand and Canada, then the data that's required for a 75 plus assessment for at least those within the home care program may be available without any additional data collection if it's done by, if the data is collected in the same format by an aged care assessment team or within the home care program, then with the appropriate data exchange facilities available, then there's an ability to move the data or share the data across the programs. So this is a dream I'm sure Chris has, and one that I have, is that the data becomes transparent for the various people that support older care, where they need more than one provider to get the best possible care. The other way of thinking about standardised assessments like interRAI is that when people move from one setting to the other, as they do, older people often find themselves in hospital, in rehab, in mental health facilities and the like, using interRAI systems means the data is symmetrical across the various settings and is easily able to be read by the various actors who look after older people as they move through these various settings that they desperately require. So to summarise my thinking about interRAI, and I'm not biased at all, as you know, interRAI uses robust data measures. They're not made-up measures. They've been deeply tested for decades, and they're accurate in their recording of information. Across settings, the same data and scales are used, so this results in data efficiency. You don't have to collect the way a person walks 3 different times for different scales. You do it once and it gets used for multiple scales. And also the way these things are recorded in different settings is exactly the same. There are integrated decision support tools. There's a training infrastructure that interRAI provides, and it would need to be built if it was used widely, but certainly manuals and instruction materials are available. It's well suited to shared care across settings and along the care continuum. And of course, anyone using interRAI would be joining a large community that already use these measures. So that's the website sites for interRAI International and Australia, if anyone cares to want to look for material there. I didn't really want this discussion to be primarily about interRAI, even though I'm a fan, more about the issues that Chris has raised, but there are some lessons from interRAI that would either directly help the problems Chris has alluded to, but also indirectly, just the way things are thought about in terms of data acquisition, clinical decision support tools, preparation of profiles for summaries that help clinicians communicate with each other and share data when they're in a shared care, shared responsibility kind of arrangement. All of those things are things that we think about in interRAI and build systems to try and support. So I think that's enough from me. We've got about 15 minutes left. I think we'll maybe want to talk to Chris, and I think Murray, I'll leave it to you to coordinate the discussion. I'm not sure if there's anyone put the thing in the chat. I can't see anything, but we can open it up for questions. I think, Michelle, we can let people talk, can't we? If we.
Yeah, that's right, Len. So I have the thanks, Len, for your talk, and thanks, Chris. Really good to match up those two those two perspectives. So I can see all the attendees, and if any of the attendees want to ask a question, you can just pop your hand up. You should have a raise hand option down at the Zoom toolbar at the bottom there, and I can allow you to talk, or Michelle can. If you're feeling a little shy, you can also just type your question in the question and answer tool as well, and we can I can read out that question and we can answer it. So we do have one question already in the question and answer from George Margelis, and I've typed in an answer while you were talking, Len, but you might want to add to this question. So I'll just read this out for you, George. So George was asking about comments on interRAI with respect to the recent clinical information system standards that have come out of the Digital Health Agency. So that's clinical information system standards for aged care. And so for those that don't know or not familiar with those standards, there's kind of 4 pillars in those standards, which are pretty broad. They cover things like connectivity of systems, information security and patient data management, communication of the information collected in the systems to family and recipients of aged care. But also one of the main pillars is is clinical care and care support. And so that's what I typed in my answer to George, was that interRAI falls fairly and squarely into that that kind of area, given its kind of clinical decision support with those risk screeners and scales and that sort of thing. I haven't dived into the standards recently, but I think some of the standards recommendations are pretty general, and I don't think they're recommending specific solutions like interRAI, but certainly interRAI falls into that need. I don't know, Len, do you want to add anything else about that?
Yeah, George, you know this only too well, but if you look at the material that Chris displayed from best practice, I think it was showing best practice. If you look at those data elements in there, I doubt that most of them would not meet any data standard. So there's a huge piece of work that needs to be done to translate those concepts into recognizable terminologies that a computer can make general sense of. And so that's another whole raft of work that needs to be done in probably all health sectors, but particularly in primary care and aged care. And obviously, when we're talking about patients that have shared arrangements between primary care and aged care programs, and for that matter, hospitals, you want to get the terminology problem sorted. So that's a kind of critical foundational issue that needs to be sorted out. We're certainly keen to work on that. I know there's an effort being made by the CSIRO team to do something in primary care as well. So we obviously are looking to harmonise the efforts around that. But Chris might want to say something about that.
Well, I think my concern too is that the software vendors appear to be slow to respond to what's going on. There is discussion that maybe needs to be a bit like Denmark, where the Danish health ministry said, right, well, all vendors needed to actually lift their game and comply with the standards. If they didn't, then they wouldn't be around. I guess there's also, in the US, there's now the Cures Act, which is really saying, pumping everyone up to say you've got to actually get with the game. If not, you're out the door. And I think they're the sort of things that we need to see happen. We've got 2 vendors in Australia that control, as I said, 90% of primary care practice software. There's unfortunately not a lot of competition out there to get them moving in a hurry. So we need external forces to move them along. That would be my first point. Number 2 is also going back to the aged care issues. Currently, when an aged care assessment occurs, as a GP, I don't get any information. Even though I might have put the referral in, no one writes back to me to say, these are the findings of the assessment. They're very keen to also say, Mrs. Smith is having an ACAT at her house on whatever date. Please, could you send a medical summary? And I'm going, that's very interesting. That was what I put in as the referral. So information one end doesn't go to where it needs to. Then they request the information from me, but then don't respond to me about what happens. And so we, as GPs, we are feeling a little bit unloved and unappreciated when we're working with older people who are vulnerable, their cognitive, their sensory, issues that then go, oh, I've seen someone for a health assessment, or, the aged care people came to see me. Yeah, what happened? Oh, I've got this letter and I don't understand it, doc. Can you help me? So, and so it goes, oh my gosh, this is going back to time and complexity, which I put up on the word cloud. These are the things that are actually the mud, the quicksand in the everyday life of a GP and a nurse in primary care, working lots of older people. So in many ways, you can start seeing why general practice is becoming very unattractive when you are trying your hardest to deliver the care for the group, but the system's not helping make it any easier. It's actually more complex on top of the complexity of the older person. So, systems thinking to actually improve the whole care experience for patients and the clinicians doing the work is much needed.
Great. Thanks, Chris. George, do you want to follow up?
I mean, not a lot I can say to add to that. I mean, again, it was a bit of a Dorothy Dixon question because I knew there was obviously a work in play there. But yeah, like Chris points out, I mean, that failure of communication, and they didn't highlight in a recent tech talk that they're looking at integrating my aged care and my health record. So I guess it's a step in the right direction, but there's still a lot more work to be done.
Yeah, no, I agree, George. That is a good step, but it then comes back to the issue with my health record being simply the PDF repository, and rather than something that is actually genuinely interoperable with our systems.
Absolutely, yeah. I mean, again, the new announcements they made a couple of weeks ago about moving to a HIE environment is positive, but it's 5 years away before it actually becomes mainstream.
Yeah. Okay. Thanks, George. So we've got a question from Isabel Freen and also from Katie Packer. So Katie, I'm just going to let Isabel's question jump in because it's related to this thread, and then we'll make sure you're next in the queue, and I'll let you ask your question live. First, moving to Isabel's question. Isabel's asking that in the CIS standards from the agency, they're referring to things like FHIR, SNOMED, CT, IHE, etc. And Isabel asked how this relates to interRAI planning. And so I'll let Len and potentially I'll put Ronald on as well to talk about how interRAI is approaching those topics, particularly the terminology standards.
We live in a world, and I think the 75 plus assessment solutions that are out there basically come from made up data items and some scales that people have inherited from. And those scales in isolation are usually pretty valid, and their data elements are unique to those scales, so they can't be used for anything other than that scale or that risk screener or whatever. And most of them aren't designed with any kind of terminology standard in mind. So there's a whole world of work to be done there. interRAI at least has got a fairly contained, several thousand data items that pertain to the kind of functional and psychosocial needs of individuals across the age spectrum. It's a good starting point for relating that to other terminology systems. But these kind of dimensions of care are not well dealt with by other terminology systems like SNOMED and Loink and these kind of things. So we have to kind of work out how to translate what these concepts are that are important in aged care and in disability services and those kind of services into that kind of world that's largely born out of the hospital and primary care environment. So yeah, it's a discussion. It's a big discussion about how we do this, but it certainly needs to be harmonised, and that obviously provides an important foundation for any decision support tools that are real time, that are really needed, which is what Chris is kind of calling out for, I think, is to see this. So I think I've said enough about that.
Okay, thanks, Len. So we might just quickly move on to Katie's question, make sure that we get into that with the 3 or 4 minutes that we have left. So probably be quick if Katie just asks her question live.
Or the other
Yeah.
option. I've seen Katie's question.
Okay. Do you wanna-
So I'm happy. So Katie, yeah, really good point. And just for the others that haven't seen that online, it's Katie's saying, look, there's physios and OTs are already doing a lot of assessments that we've mentioned as objective measures of sarcopenia and physical frailty. And all of that information could be shared. And I think that's absolutely fantastic. However, many allied health professionals don't seem to want to write to GPs to get that information into our records. The aged care teams don't write to us, as I mentioned earlier, so we've got gaps there. And in acute hospitals, a lot of those assessments are actually done, but often they do not get put in the discharge summaries. So we don't actually have that information within a discharge summary. So these are some clear gaps. And when I was director of junior doctor training at a public hospital in Adelaide for about 10 years, and I would actually go and look at what was happening, work with the allied health and the interns, and say, well, here, you've got a fantastic assessment in this inpatient setting. The intern has not put it into the discharge summary. So as the GP receiving the letter, I've never seen it. And so I then have to go and get a repeated outside. So these are some of the structural issues within communication from acute, subacute and primary care. But the other really important element here is the majority of older Australians are currently not in the aged care system. And so if we're going to actually change the trajectory of aging in this country, general practice, primary care needs to be doing these early assessments. So just the simple checks for sarcopenia and frailty screening, so that we can actually talk to people about it, and at least start getting people to think a little differently about their own healthy aging trajectory. So that's, I think, so that's where I'm really keen to actually push, where we can actually do things a lot earlier. We look at pre-frailty is well described, just like pre-diabetes. In general practice, we've been focused on diabetes, early intervention, reducing complications for 20 years. But now that we've got an understanding that frailty is something we can pick up earlier and change a trajectory, then we should be doing it in general practice. So I'd love to have a team of OTs and physios working with me in my practice so we could actually share that information. However, our funding limitations and this lack of team-based care in primary care is going to cause that not to occur. The other element I'd just like to add, I know there's only a few minutes left, Murray, but there is currently a Department of Health and Aged Care consultancy going out to look at reviewing health assessments in this country. So that is currently a survey out, and it closes, I think, around about September 30, where clinicians of all different types can put their information in there, what they think of health assessments. But really importantly, what the department is actually asking is, how can we get evidence into practice? And so much of what we've been talking about today, they want to see what ideas from users of health assessments, and especially they'd love to hear from patients about benefits, what they're seeing. So I'd just like to get everyone to think about, filling out the survey online. And it's pretty straightforward, but I think that's what's happening right now. That the department has actually called for a review of health assessments of all type, not just 75 plus, but heart health checks and 45 to 49-year-olds, those sort of things.
Thanks, Chris. And 30 seconds we've got left. Katie, do you just want to, using your audio, respond to any of that?
I think Len's totally right about us needing some sort of terminology for function, so that we can communicate between different people. And I think if the software vendors are going to redo those forms, they need to do them smart on fire so that we can be communicating that information. And I think looking at ways we can transfer information from one outcome measurement tool to another would also be really helpful. But I just said in the thing, let's put dynamometers in people's kettles so that we can get strength being tested.
Right on.
And the WHO iCode framework is also, I think, interesting to look at too. It's gives some suggestions, I guess, of things that can be tested, and then things that can be done from there as well. So I don't know whether incorporating that into some of the interRAI stuff, or how to get different things to talk together so that anyone who's doing any of these assessments or collecting any of this good information, that it all comes together. Yeah, thanks.
Katie, what was that tool you mentioned?
It's the World Health Organization's iCode framework.
iCode. Okay, thanks.
I'll send it to you, Chris, if you like. I've got your email. I'll send it to you.
I love it. Thank you.
Okay, that's excellent. Thanks, everyone. We don't have any more questions queued up, and which is perfect because we're past time now. And thanks, everyone, for your questions and input. That's really excellent. So I'll just hand back to Len and Chris to wrap up the webinar.
Yeah, thank you so much, Chris. That was really informative, interesting, and got me a little bit excited about doing something about this. I don't know why we don't just get together and build the correct system, implore the government to actually pay the software vendors to build it with some quality checks and be done with it. That wouldn't actually cost a lot of money, considering what's involved here. I mean, you know, you could just pay the vendors to build what's needed, I would have thought, rather than trying to get the market to get them to do it, which is obviously doesn't work. However, after this session closes down, Chris and I might have some more chats and might talk to some other people. We've got a bit of energy around this, I think. So
We'll look forward to it, Len. Thanks for the opportunity. I think that as more of us are now seeing more older people in our clinics and recognising the gaps in care, and I think that's the thing that really opened people's eyes about what they could be doing rather than going, I've got to remember to do X, Y, and Z. And as we know, in a time-poor, complex environment, busy clinicians, no matter how good they are going to actually leave things out. And it's all those little things that get left out. It's like the Swiss cheese model of safety and quality and care. Then people end up in the ED as a result of something happening. And so we look at that as an end outcome of not getting the right things done in primary care. So that's my 2 cents worth about why we need to be doing something fast, why government needs to invest more in primary care and primary care systems.
okay, Chris, we could talk all day, so we're going to stop.
Okay. Thanks very much, everyone.
Let's keep the conversation going. Okay.
Okay. See ya.
Bye.
For those of you listening to this conversation who may have further interests in interRAI systems, please visit our website, interRAI-au.org.